Thank you, Brent. Well, good morning. I won't be making anybody stand up and dance and sing. I wanted to make that clear. Not even once, let alone twice. But I will be giving you a presentation that I actually give frequently throughout the state to many different groups. I've done this with primary care groups, with hospitals, both in group and individual. And this is a long, hard slog. The premise of the talk is that HIPAA is frequently overinterpreted and is frequently taught in a way that is way more restrictive than anything that is written in the federal law or the federal regulations, and is regularly taught by privacy officers who have not actually read the HIPAA regulation, and is regularly interpreted by lawyers who do not read the regulation either. And this creates a lot of problems. It interferes with healthcare, it creates bad outcomes. So I know as I tell you this, you'll be thinking, but you know, I've had this discussion with my local hospital and they just don't buy it. And we'll be giving this talk again at Missouri Hospital Association in the coming months, and we attempt to work with the hospitals on a one-to-one basis. They're probably the most recalcitrant on HIPAA. You will get on the website later, I had intended for you to get as a handout a summary overview, a written narrative of what I'm going to say, and also an actual copy of the HIPAA regs. I found the most effective way when I work with privacy officers, risk managers, and lawyers is they say, well, you can't do this. And I say, well, here's the reg. Show me where it says I can't. Here's where it says I can. So since we're talking about the reg, show me the reg. They usually change the subject, but you know, at least then we're talking about something other than our delusional fantasies about what federal regulation is, which is what the conversation most commonly is. So I want to admit up front that even though I give you this information, you'll still get resistance from many agencies. That said, let me go on ahead through. So I'm going to focus on the way that you can disclose personal health information, commonly referred to in an acronym as PHI, to benefit the individual. Covered entities, meaning anybody that falls under the HIPAA regulation. A covered entity is any entity that is defined in the reg as being covered by HIPAA. Often interpreted too narrowly. This is to the detriment of individuals, and it's often vital to get information out. I've seen many more patients harmed by not sharing information than by sharing information. Many more people get harmed by not looking at information that should have been shared. So the big message is that HIPAA explicitly allows you to share personal health information for the purposes of treatment, healthcare operations, and payment. It actually allows you to share information absent patient consent and even over the objections of patient consent. How many people are surprised to hear that you can even share over objections? Yeah, well, that's what the darn thing says. Whether you agree with the policy or not, that is the current federal regulation. So let me walk through each of those definitions: treatment, healthcare operations, and payment. And this is from the federal regulatory language. Treatment means the provision, coordination, or management of health care and related services, not just health care itself, but health care related services by one or more healthcare providers, and includes the coordination or management of health care by a healthcare provider with a third party, consultation between providers relating to a patient, or referral for health care from one patient provider to another. This is a very broad definition of what treatment means. It includes referral, it includes consultation, and it includes not only the healthcare provider, but providers of related service. What would a related service be? It would be some service the person is getting or needing as a result of their healthcare condition. Probably the most common one you may run into is specialized housing. If somebody needs to be in a residential care facility as a result of their healthcare condition, the residential care provider is a service provider, is a related service. That would be a related service. And you can share information if you think that's in the best interest of the person. Authorization is not needed to use or disclose personal health information for treatment purposes. Treatment by design is defined broadly. Treatment covers the coordination or management of healthcare among providers and related services, which I just discussed. Related services can include social, rehabilitative, or other services associated with healthcare, so long as it's a service that's needed due to the healthcare condition. Department of Health and Senior Services, the old name for HRSA when HIPAA passed, remember they've renamed the federal agency since this regulation passed, so that's Department of Health and Senior Services, the federal agency that is now HRSA, that was the agency when the reg passed, believes that disclosures for treatment purposes are appropriate for timely and quality care. Treatment applies to individual and particular patients, not to groups of patients. So when you're disclosing personal health information for the purposes of treatment, you are disclosing information about a single patient. It can be about a prospective patient. So if it's somebody that you anticipate serving, somebody that you're going out and looking for, somebody that you are getting a referral or making a referral for, that's what's meant by a prospective patient. Minimum necessary disclosure does not apply to treatment. For disclosure for operations and payment, it's limited to minimum necessary disclosure. But for the purposes of treatment, you can really disclose whatever you think is useful in the context of providing good care at that point in time. Ask questions now. Let's go. Yes. So the question that we had is, can we just give the hospital a list of our patients so that if Mary Jane comes in and makes Mary Jane's name, they go, oh, well, we don't have to worry, but let's coordinate care with the first. So there's 3 levels. So the question is, can they just give a list of their patients to the hospital? And they're saying consents have already been signed. There's several ways you can do this. This could be viewed as either treatment relating to the whole group of individuals, or this could be healthcare operations, which I'll get to. But you are covered for doing that in several ways. The answer is yes. Number one, no, the answer is simply yes. Number one, if you've gotten a release of information from them all to the hospital, absolutely you can. Even if you did not have release of information, if you knew from the history they gave you that they got care at that hospital in some reasonable time, like the last 5 years or something, then there's a treatment relationship there. And since you know that's a provider, you can tell them you're a provider. That makes it individual treatment. Right. If you anticipate, and you can find out if they've been with the hospital by looking at cyber, of course, or by looking at your PROAC individual screens. Both of those would be treatment individually. When I get up to healthcare operations, I'll tell you how you could do it if you didn't want to construe it as individual and you just wanted to share groups. But if you have consent, or if you know they've had a relationship with that hospital, you can tell them without consent. If you intend to refer them to that hospital, you can send the list. Yes. If you put on their plan, if there's emergency, I'm sending them to the hospital. That's an intent to refer in the case of emergency. Mm-hmm. Yeah. Now, the term treatment, yes, ma'am, we'll take that question now. In general, yes, in general, they've been incorrectly trained and they are incorrectly informed. It is true. The hospitals are the biggest problem in the system. We talk to them regularly, and progress is very slow indeed with them. So, what you want to do is model the behavior you want to see and say, look, you're misinterpreting HIPAA. I know you think you can't say anything, but rather than argue with you, I'm going to tell you everything you know. I'm going to tell you I have this patient. They're under medical risk. If you can do things to help, if you could do things to help, which you can and you don't, that creates liability. You need to think about if you're liable that you could have coordinated care and you did not. In fact, Joint Commission at discharge requires you to coordinate care, and I haven't gotten anything from you. That's a failure under your Joint Commission standard, and you need to think about the liability you have if you could have done it and did not. So the problem with their decision making is they are... Okay, we'll write this up. Yeah. Yeah, we're recording it, and I'd be happy to create some slides around that. So the problem is they are more adverse to the bad than seeking the good. They never get praised when good things happened if they're either the hospital lawyer, the risk manager, or medical records. Nobody says, oh, thank God you revealed that this person had been with us, you averted a heart attack. Nobody does that. They only get beat up if somebody complains. And they get beat up just if people are unhappy, not if any reg has been broken. So they are driven more by fear and anxiety than by seeking the greater good. And so the strategy should be, since what motivates them is anxiety, it's important to create anxiety about not sharing information. So lately, instead of saying, oh, it's good, it's the right thing to do, it's okay, I say, you could be liable if you could have coordinated care and you didn't, and this person got harmed, and I'm telling you we did this, I'm going to put in my note that I asked for this information, you wouldn't tell me anything. And, if bad treatment occurs, that'll be in the record. You could have. So we try and create anxiety on the other side. It's a long, hard slog. I don't want to give you the impression that these arguments, for me, when I give them, work about 1 time out of 4 or 5. It's hard. They hunker down and they shut up. Treatment, other questions about this point? The definition of treatment does not generally apply to psychotherapy notes, but by this we don't mean the little 12 lines you do to justify billing 90804 in the past, where you say, discuss conflicts with family members, went over maladaptive problem-solving skills to reduce conflict, that kind of broad stuff it does not. What they're talking about are like process notes, the things that go on for 3 pages, and then he told me the dream about the horse, and then the next thing they talked about the mother abusing him. It's that long, voluminous stuff, and I haven't seen you produce one of those notes in the last 10 years in any of the records I've looked at. I don't think any of you currently produce the kind of process notes that is construed as psychotherapy notes in this definition. They're gone. Yeah, those guys are gone. Yeah. So the following undertaken on behalf of a single consumer, a single patient, not a population, or treatment activities. Treatment includes case management, care coordination, disease management, health promotion, and outreach programs. So everything you're doing as part of Health Homes is also construed as treatment under the definition of HIPAA. That's treatment. Any questions about treatment before we go on to healthcare operations? Healthcare operations includes quality assessment and improvement, staff evaluation, insurance-related activities, administrative functions, business planning and development, and business management and administration. Healthcare operations are activities that support treatment and payment functions. They're often population-based. Covered entities may use personal health information it maintains for operations, and it can be disclosed without authorization. But for healthcare operations, the minimum necessary applies for both requests and disclosure. So you don't send everything in general, you don't send your whole psychosocial evaluation. An example of healthcare operations would be if you decided, you and your local hospital decided you wanted to coordinate care and you wanted to send that list. That could also be construed as healthcare operations. It is a quality improvement program. You're attempting to look at the patients you share together. It's quality improvement. But in that case, you would not send their list of medications, their list of diagnoses. You would just say, here's the people we're seeing, and you'd send, the usual 3 identifiers: name, social, DCN, date of birth, 4 identifiers. That's health of your whole population. You'd say, here's who we have in common. Let's have a meeting once a month or quarterly where we can talk about how we can do better between us on them. You've now set in place a quality improvement process, and you're doing healthcare operations with a population. So you could construe what you wanted to do either as individual treatment for those individuals. It can also be construed as operations. Much of this stuff is overlapping. Healthcare operations, when population specific rather than individual, includes case management, care management, disease management, health promotion, and outreach, the same areas. As you're just doing it with a population instead of it being motivated by a particular individual. Payment, it's very interesting. The hospitals are very upset about revealing anything related to actually delivering health care to the individual. They don't bat an eye for revealing absolutely anything to get a buck. It's all cool if it's payment. Payment encompasses the various activities for healthcare providers to obtain payment, be reimbursed. Common activities include determining eligibility or coverage to adjudicate claims, risk adjustments, billing and collection activities, reviewing healthcare services for medical necessity, utilization review. Payment can only be related to an individual in the covered entity. Covered entities may disclose PHI to any other entity regardless of HIPAA status related to its payment activities. The other way, if you wanted to share information with the hospital, is you could say, look, I want to pay you $1 a year for every patient I have that you have just so you'll talk to me about them. And all you have to do to get your buck is talk to me about them. And now we're under payment, and it's all cool. You can be a payer to the hospital for some nominal amount that puts you underneath. So far, I haven't had any hospital take me up on that. But MoHealthNet does that with pharmacy claims. They pay 50 cents of the dollar copay for the dual eligibles, which gets us about 80%, but not all of the claims. Cyber access and CMT data to some extent drives you nuts on pharmacy because it's missing about 20% of the claims. Our philosophy is we're better off getting the other 80% and sharing it, and how we get that 80% is MoHealthNet pays 50%. It's a payer. It gets the claim. And it's worth the 50 cents on every claim to have the data. Minimum necessary applies for disclosure for payment. So minimum necessary is for operations and payment. For treatment, it's not minimum necessary. It's whatever you think is good and useful. Individuals have the right to request restrictions on how a covered entity will use and disclose PHI for treatment healthcare operations. They have the right to make a request. The covered entity is not required to agree to an individual request for restriction. But if you agree to the restriction, then you're bound by your agreement. And there is the quote in the federal reg. If you don't believe me, Google up 42 CFR 164-522 sub A. They can object, and as long as you haven't been ill-considered enough to write a policy saying you honor individual objections in your agency, go look for that policy. If you have it, change it. If you haven't agreed, you can still do it. HIPAA also lays out rules for when somebody cannot agree to disclosure. If you think they can't agree, you still need to ask. And again, agreement to disclosure is like any other informed consent. In general, we get informed consent for everything, but we require different levels of informedness based on the risk-benefit of whatever we're doing. If we're going to do something that's relatively high risk, like transplant your heart, then you have to really understand everything. You actually are able to get implied consent for drawing blood. You don't make anybody sign anything, and the risk is so minimal, and it's all upside potential. And that's the way it is for much of this disclosure. you don't have to say, oh, are you really competent to disclose? The question, if they cannot disclose, if they're delirious and can't even indicate yep or nope. And of course, if you haven't made a policy to agree to their restrictions, then this isn't an issue. You can also disclose when you reasonably infer from circumstances that the person would not object, whatever the heck that means. Disclosures permitted in circumstances when they can't indicate agreement or when they object. This includes emergency situations or their incapacity. Department of Health and Senior Services wants to balance competing interests of privacy and sharing PHI. The rule specifically makes provision for disclosure of PHI directly relevant to a person's involvement with the individual's care. So if you are wondering about disclosing to somebody that is not a healthcare provider, if that individual is directly relevant to and involved in the person's care, often meaning if they're living with the person, if they're assisting them to remember and keep their appointments, you can disclose. If it's somebody, it's a family member, and the person doesn't know what's going on, you can disclose. Or a significant other, or the group home. If the person's incapacitated, covered entities can exercise professional judgment to determine if it's in the best interest. This is the key point of documentation, is to say, you know, this person is in such and such a strait, this is the relationship, I believe it's in their best interest, and have conferred with these and given them this information. Or if you can also infer, again, from the circumstances that the person does not object, that there's an absence of objection. I've been a little duplicative here, that you can disclose when it's directly relevant. I need to slim down my slides. And this can range from summary information to detailed condition, treatment information based on the degree of their involvement. It's kind of like, what do they need to know to continue to help out effectively? When considering whether or not to disclose, in the cases of incapacity or emergency, professional judgment can take into account potential for harm to the individual. In cases involving abuse, neglect, and domestic violence, there are broad exceptions to HIPAA in terms of abuse, neglect, and domestic violence. Yes? Yes. So I think of this. So the question is, if somebody's disappeared and you're trying to find them, can you ask around the neighborhood, because then people know you're looking for them? And my answer is, you can construe that as an emergency. If you think the person has medical conditions that they would come to harm if they didn't get adequate care. So on the one hand, I believe if you write it up, we believe this is a potential emergency and we're going to start asking. You would have adequate coverage. The other thing is, I'll show you later at the end of the slide that individuals cannot sue you under HIPAA. All they can do is complain to the Office of Civil Rights. There are civil and criminal penalties, but there has never been a penalty for an individual's treatment information being revealed. The only penalties have been for large banks of groups of information. You know, if Aetna revealed 100,000 people or something like that. I challenge anybody to bring me a single case of a civil penalty or criminal penalty where PHI was revealed for purposes of treatment. And that's another thing I do at the hospital. Well, can you name even one instance? Because there hasn't been one nationally. 15 years in, not one penalty. People say, oh, I could use my license. It's been 15 years, gang, you know. The third thing is you make the point that you would rather err on the side of doing the right thing. Well, the way I look at it, you know, I'm approaching 28 years as a licensed physician. And within, 6 months of getting my full license out of training, I was part of a malpractice lawsuit around a woman that had an ectopic pregnancy in seclusion, restraint, and died. I had decided early on if legal fears was going to keep me out of the field or not. My impression, if you don't want to get sued, you shouldn't be involved in healthcare in America. That's a bad decision. That's like not wanting to get wet in the rainforest. You know, that's why we have insurance and everything. But more importantly, I found I do much better when I get in the stand and explain why I did what I thought was the right thing for that person that day, than when I get in the stand and explain why I did something that was stupid because I thought it wouldn't get me in the stand and get sued. I always assume I'm going to be sued. And I'd rather stand up there and say, Your Honor, I thought it was best for that person, than say, you know, Your Honor, I thought that I wouldn't get sued if I did that. That sounds dumb as dirt when you're in the stand explaining yourself. So there's 3 tiers of reasons. You can document it, you can consider it and document it an emergency. You can comfort yourself by the thought that nobody's been penalized. And you can say, well, if I do get whacked, what do I want to explain? You can assume worst case scenario in either. You're going to get whacked. Other questions? Adult abuse. 3 circumstances allow for disclosure of PHI reporting for abuse, neglect, domestic violence if required by law. And in that case, you do need to let the person know that you're reporting that they're being abused. Say, look, I got to tell the agency you're being abused. Of course, if the person agrees, it can be disclosed without the individual's agreement if the disclosure is authorized by state statute or regulation, and either you think it's necessary to prevent harm to the individual or others, or they're unable to agree. I always err on the side of reporting abuse. Yes? On payment, yes. Question on information on payment. The question is if a person pays out of pocket for their service. You then cannot release the information for purposes of payment. You can still release the information for purposes of healthcare operations or for treatment. You're required to honor it for payment because that's all they've done. There's nobody, why could you talk to anybody about payment? If you agree to the restriction, then you have to honor it. If they say, I'm going to pay you, I don't want you to tell, and you say, okay, I'm not going to tell your insurance or any other payer because you're paying me, I have no reason to talk to anybody else about payment, that I'll honor. On the other hand, I know you're going to these other 3 doctors, and if I think it's really in your best interest, I'm going to tell them. You can still do that. Now, they may say, then I don't want the service. But even if they just pay, you're only restricted if you agree to the restriction. More thoughts? Do you want to have a dialogue on this? So my concern would be if you agree, I would be weighing and balancing what made sense to restrict and what was not. You could become aware of something that could directly relate to the other entity's treatment that could be directly dangerous and detrimental. And I personally, morally, I think it's wrong in that case. And secondarily, I think I get more liability by agreeing to a dumb restriction. So I would urge you to look up 42 CFR 164 522 sub A and take it to your legal counsel and form your own opinion. I think you could agree to it if you wanted to. I don't think you have to agree to it. Now you have, you know, if they say I don't want you to reveal, you should say, of course, but I'm not agreeing to that for treatment, only for payment. You know, if your employer is paying, I won't tell your employer. I won't tell Aetna if you're covered by Aetna, if you're out of pocket. Talking to family practice is another matter. Mm-hmm. I would, well, I'd be interested if you'd be willing to share the legal opinion later and see what basis they put it on. I'll quote you some Missouri statute later. Yeah. So again, you need to think, so here's the other way I work with this at DMH and with Mo HealthNet. On any executive team, everybody has a different role. My role is to advocate for the best possible medical care. The chief fiscal operator is to make sure we stay in the black and not lose money. The lawyer is to make sure we don't incur liability. Those things are not always reinforcing each other. Some are mutually exclusive. I want to spend more money than CFO might want, and lawyer may want to do less. The best way not to be liable is to never do anything. Lawyers will, in general, tell you to do less in order to avoid liability. It's the executive's office, your CEO's job, to balance what the operational demands are, what the fiscal demands, what the legal liability demands. And I often see problems when they can misconstrue either my medical advice, because I'm really just advising the CEO. I'm not giving the CEO a doctor's order. But often the CEO will treat their legal advice as if it is a court order. It is advice. And sometimes I get the question back from Keith Schaefer, okay, Joe, this may not be the absolute best thing clinically, but we have other constraints politically, financially, operationally. How can I minimize my clinical downside? So I would urge you in your clinical roles to be telling your CEOs to go back to your lawyer and say, okay, you know, I know we get some liability here. Now you've told me I have some liability. How do I minimize it? And what's my worst downside? And often the worst downside is, oh, if they catch you, they'll tell you to cut that out. Anyway, that's management team discussions. We've had those discussions, haven't we, around the table? Yeah. Other questions? So you have to understand, I'm taking the clinical viewpoint. I am urging you to interpret HIPAA at the outer edge of what's permissible under that law. Legal will urge you to interpret HIPAA at the most conservative, safest limit. There are gray areas. I want to admit up front there are gray areas. I think that's what you're getting. Your legal is giving you what's absolutely safe. I'm giving you what's absolutely defensible, potentially defensible, but yeah. And the CEO has to decide where they want to sit in that gray zone and what's worth it and what isn't. And the good question for a CEO to ask is, okay, you've told me I have some risk. How do I manage it? And if I do incur that risk, if it happens, what's my cost going to be? You know, is it going to be somebody dead? Is it going to be a $100,000 fine? Is it going to be don't do that? What's it going to be? What's the downside? Yes, there's a question in the back. Jaron. Mm-hmm. Yeah. Oh, and the release of information. Yeah. I think it would be useful to quote the part I just, some of the quotes on this about how you can release information absent patient consent. And I think it would be important on the form to quote the CFR. I think that may change some agencies in the long term. I don't think it'll persuade medical records not to follow their policy that afternoon when you want when you want that piece of paper. Yes. I actually don't think you have to have one. I think it doesn't, there's 10,000 of them out there. They're all about the same. There's stacks of them in my drawer at home that are signed. I think it's very little trouble to get one signed in general. They're pretty much boilerplate these days. So I disclose and exchange PHI to tons of agencies I don't have agreements with. I also have tons of business associates agreement. If the other party wants one, fine. You know, send me yours over. I'm happy to sign it. I've never seen a business associate agreement make much of a real difference one way or another in any operation. Have any of you seen some real change of anything occur as a result of a BA? No, you know, it's ritual paper. And it doesn't really take any time. Let me go back a little. Other questions? Okay, child abuse. I think I had the Missouri law on this. Oh yeah, Missouri statutes do require reporting by mental health and healthcare professionals. 565.188 RISMO mandates reporting abuse and neglect for people over 60 or if they're disabled and between 18 and 59. And 198.070 mandates abuse and neglect for nursing facility residents. So if you're treating somebody that is disabled, a good number of your people are on disability status, that is actually a mandated report. In both instances, though, if you make a good faith report, you're immune under Missouri law from civil and criminal liability. They have to show you are being intentionally malicious. The PHI described should be sufficient to provide the investigators with necessary information, but beyond that, minimum necessary. HIPAA provides for disclosure of PHI for child abuse in two ways. State laws regarding child abuse are carved out from the preemption on state law. In general, HIPAA preempts state law, except in the case of reporting of child abuse. There, more stringent local state laws apply. Child abuse reporting is allowed to a public health activity to avert a serious threat to health or safety. Let me go on to HIPAA and 42 CFR, substance abuse reporting. There's nothing in HIPAA that changes or affects 42 CFR. 42 CFR, when it covers somebody, does trump HIPAA. So the permissions under HIPAA don't apply in the cases where 42 CFR applies. However, 42 CFR Part 2 applies only to specialized alcohol and drug treatment programs. So if you hold yourself out to the public, or the treatment program they're wanting information from, if you have multiple programs, if you have ads out, websites out saying substance abuse treatment, then 42 CFR would apply to treatment occurring within that program. If you don't, it does not apply to general medical care, which render drug and alcohol services incident to their medical care function. If you're a CMHC that doesn't have substance abuse treatment on its website or have ads out saying that, then 42 CFR does not apply. What is protected is that the person got treatment. What is not protected is the information that they have a substance abuse disorder. So if you're in primary care, if you're in a general CMHC, and part of the history is they're using meth and getting drunk all the time, if you're not a substance abuse treatment program, that is releasable. And that makes sense in terms of public policy. What you want to do is not disincentivize people from seeking treatment. You don't want to provide cover if they bounce in the ER all the time getting drunk. Well, we can't tell anybody because that's protected. What public policy does that serve? In general, enforcement on HIPAA, as I said, is complaint-driven. HIPAA does not give people the right to sue. The Office of Civil Rights investigates the complaints. Civil penalties and criminal sanctions are allowed. I've never seen reported, and after talking to multiple audiences for many years, I have yet to have somebody put up their hand when I say, tell me about release of treatment that resulted in a penalty. If you find somebody that actually had to pay a penalty for individual release for treatment purposes, please call me up immediately. I'll add it to the presentation. Missouri statute under 630 140-3, facilities or services may disclose information and records to any of the following to persons and agencies responsible for providing care and services to such patients. This is why I'm a little incredulous about your legal opinion and would like to discuss it further. There's explicit Missouri statute that says you may do this. Your department contract that you have as an administrative agent, as a CMHC, under clause 3.5.11 requires you to share PHI. For department clients, the contractor shall provide coordination or management of healthcare and related services by one or more care providers, including coordination or management of healthcare with third-party payers, referral of a patient to healthcare. You'll notice this is the exact language from the federal regulation. We are contractually expecting you to do this limit, and you've agreed to this. You've signed these contracts, which is the other thing you can show your lawyers, that you agreed to do this stuff. Authorization from the client is not necessary to disclose personal health information for the activities above. You actually, as organizations, have agreed in a contract that you will not require authorization, that authorization is not necessary. That was pretty sneaky of us. His question is that in the substance abuse contracts. That's in the administrative agent contracts. I haven't looked at, I don't know if it's in the substance abuse contracts. We put this in back when we set up DMHnet and added the primary nurse care manager. We actually revised all your boilerplate contracts. And this was at the request of the coalition to prove that there was a common governmental understanding and that there was state agency support for this broad interpretation of HIPAA. This was at the request of the coalition, and we heartily agreed with it on the DMH side. So currently, your major opportunity for summary information is still cyber. PROAC hasn't not yet programmed in the ability to print off your individual IHP, the integrated health profile. Hopefully in the next couple months you'll be able to print down an IHP. So I'm going to now talk about what we would like to see you do, because you've contractually agreed to coordinate care. We're paying you extra fees to coordinate care. It's a core part of the rehab option before we did health home, and you're getting PMPM to do it under health home. So you're contracted and paid to do this stuff. So I thought I'd be explicit about what we'd like to see you do. Basically, we would like to see you get a broad snapshot of the care the person is getting in the hands of any new care entity that they go see. So the Cyber Access Summary of Care can be downloaded as a PDF file and printed off. It has the 3-year history I'm sure you're aware of medications, treatments, and diagnoses. Many other providers don't use cyber. They won't look it up. So your role is to get the copy in front of them for that patient at that interaction. You should do this whenever your client or patient will be meeting a new healthcare provider. Either the patient should bring a copy or you should send them a copy. Why? Because the first thing they'll need to do is get a medical history, and that eats up a lot of time. It takes a long time to ask about all those illnesses, all their medications. The people you serve have 8, 9, 10 different diagnoses. They're on 10 or 12 medications. And their diagnoses interfere with concentration, memory, and organization, and we're depending on them to remember all this stuff and tell us? What kind of strategy is that? They can't remember all that. I can't remember it without looking at a record. So the strategy, because it saves time, you're only going to get X amount of time with that new provider, whatever they scheduled, 20-minute visits, 10 minutes, half an hour. And think how much more individual attention the client will get if they're not playing question and answer about all those diagnoses and meds. You say, here, doctor, here's everything they've had the last 3 years. Most doctors will then spend about 60 seconds flipping through it, and you'll get right down to the problem. The other thing you can do is when you get that summary, you can put a little post-it on it saying, here's the 2 main questions we have for this visit. Now you've given me information that makes my life easy. You've made it easy for me to decide what I'm going to attend to. It really, and I like this visit much more than I like most of my other visits because it's quick and easy. And I was anxious because I knew it was a mentally ill person, and now, this is cool. So it's a quicker, more accurate medical history for a new provider. When you should do this, Whenever a patient or a client is first meeting with new primary care or new medical specialist, they got a new OBGYN, they're going to go see the endocrinologist for diabetes, whatever. When you have a new psychiatrist in, yes, ma'am. Let me talk to them. This is the first I've heard this. I need to go talk to ACS Heritage. Okay, I'll talk to ACS Heritage. Kimberly did. Okay. I believe so, but I will double check with MoHealthNet and ACS Heritage Xerox and get back to you. This is the first I've heard this. I'm sorry. I'm glad you did too, yes. Let me see if I can work something out on this. Okay. First I had heard this. Yeah, it probably is, but we'll talk to Jennifer Cornelius and see where we can go. New hospital admissions, or if you're requesting a provider to address a care gap, if you want them to get them on an inhaled corticosteroid for their asthma, or maybe start a statin because their LDL's high. Why do you want to do this? This is my inspirational side, ignorance. It's amazing how much easier it is for a team to work together when no one has any idea where they're going. Communication's good. How you should provide this, and again, I'll get back to ACS Xerox, what I've been doing in my practice. Since they set up the portal in 2005, so I'm only 7 years in on this. I print a copy and sometimes I give it to the patient if they're going to go over to University Hospital instead of the FQHC, yes? Well, I give it to them to give to their doctor. I tell them, I have the case managers take a copy with them. We fax it over to the other office because they're not going to get on the portal. I will talk to ACS Heritage Xerox. This is a problem. I'm really glad. I did not know that was the way they were training this thing. Okay. Yes. And they haven't detailed somebody in their office to do it. Yeah, but our job is to make it easy so they do what we want. Her point is they have access anyway. Okay, yeah, they intend, so ACS Xerox would intend for these people to see it anyway. Yeah. Okay. Why do I want you to do this? One last, look at that. Why did I do that? I have to show my last inspirational slide. Don't worry, it's only a joke. The reason you want to do this hazards, there's an island of opportunity in the middle of every difficulty. That's that little bit of time you get with that other provider. You have something you want them to do for the client. You have a little 15, 20-minute window. You miss that and you're pretty much doomed. It's going to take another month to get in to see them again. It is a small, ripe moment. I will get with ACS Heritage. Thank you for the redirection. Those are my prepared comments. I'm ready for dialogue. I'm glad that you've identified points of friction. We can work on them in the future. I appreciate all the questions. You get the gift of time until the next session.